So I love the topic of our last panel. It's a discussion on the future of health-literate design. And anything that has design in it is always extremely interesting because it's really innovative. So I'm looking for an innovative discussion. Our first speaker is Dan Morrow. Dr. Morrow is the chair of the Department of Educational Psychology at the University of Illinois, Urbana-Champaign. Next, we'll have Heather Rennie, who is the managing counsel of the regulatory legal group at Merck. And finally, we'll hear from Mike Wolf. Mike is a professor of medicine and learning sciences and associate division chief of research in the Division of General Internal Medicine at the Feinberg School of Medicine at Northwestern, and he's also a member of the Roundtable. Once again, at the end, we'll have a discussion and hold your questions and comments, so we can do that at the Q&A at the end. Dr. Dan Morrow. I'm going to take my water.
Please. Thank you very much. Good afternoon, and I'm really happy to be here. I've not been to one of these meetings before. I think as I'm listening to these talks, two things stand out for what I'm going to talk about. That'll be a little different. The main one is I'm going to talk probably at a more micro level analysis of patient comprehension. So I'll work you through that. And then the other is the focus of my work is on aging and cognition. So there'll be a lot about older adults and how they may cope with electronic information. So there's too much information here. I'm not going to get through all this. I'm sorry. But what I want to do is just remind us of what we already know is that there's a changing ecology of health information that may have implications for the cognitive accessibility of health information, especially for older adults. And then I'll step you through a theory-based approach to trying to redesign, trying to improve some of the enormous amount of information that's available on the web. So I'll say more about that as we go. And then I have 3 studies about improving web-based health information for older adults, and I will probably just tell you about the first one. But you can ask later about the others. Okay, so just to remind you, we are in this well, we're probably past this transition, but traditionally there's more of a paper-based approach to health communication, where you may talk to your prescribing physician and learn about a new medication that you're going to be prescribed. You leave that encounter maybe with print pamphlets about the illness and the medication. You go to the pharmacist and hopefully get a chance to talk to your pharmacist about the new medication. Then you start accumulating print. The information on the label, as we've been hearing about, CMI information that you may take home. Of course, if these are chronically ill patients, then you are probably adding to a big pile of print already for other medications. Once you're home, you may be relying on various paper-based tools to help you manage these medications. You may have a paper list of this. We've seen various examples of this today. A list of medications with key facts that will help you take them as prescribed, help you load the pill organizer perhaps, and more pamphlets. And we're changing, as we've already changed, but we're still evolving to a slightly different situation where you may have looked in your patient portal to get some information about why you're going to see your physician. So you're primed with electronic information through access to your patient records. You may have access to pharmacy-based health information on the web. In addition to the print, you go home and you potentially have a lot of electronic tools, as we've been talking about, to help you manage your medications. You may have an app that tells you about medications that you're taking. Back to the patient portal, where you're getting information maybe about the clinical test results that motivate the prescribed medication. And you're probably surfing through many different websites, American Heart Association, American Diabetes Association, a great number of web-based sources of health information. This poses challenges. So this new ecology, sort of electronic rather than paper, allows new affordances for comprehension and also puts new constraints on how we understand information, health information. In terms of access, there's a remaining digital divide challenge, but increasingly that may have more to do with cognitive access rather than technology access, where we have to do in a different way. We have to find, search for, understand, and evaluate the information we're finding on the web. And then hopefully that's a basis for use related to taking medication. The act of reading itself is changing. Maybe we're browsing more than we used to in a paper environment. We're not reading as a linear act maybe as much as we used to. We're managing multiple documents, maybe guided by hyperlinks, search engines, and we're reading more and more in a multimedia context. I mean, this is obviously also true for paper, but I think it's ramped up a lot with electronic environments. So the requirements for comprehension have changed a bit. So there's more emphasis or more need for integrating information across paths of search in multiple documents. And learning is always to some extent self-regulated, but it's more and more so in electronic environments where you really have to monitor, am I understanding what I'm reading? Can I evaluate it to make intelligent decisions about, well, where should I go next? How do I understand what I just read in light of the new documents I found? Should I go back and read again? Now, there's a lot of interesting issues there about how learning and reading is changing in this environment. For older adults, it may be a particular challenge for reasons we understand. I mean, older adults are more likely to have chronic illness that leads to self-care, more medications that need to be managed. So older adults are more and more having to negotiate this changing ecology of electronic digital information as well as paper information. So there may be older adults are also experiencing age-related changes in cognition, which may pose additional, in addition to the electronic environment, may be increasing cognitive accessibility issues related to age-related changes in literacy and cognitive abilities. And there's a large and growing literature that documents that problem. So what I want to spend some time talking about is an approach that my colleagues and I have been using to try to help older adults better understand information, whether it's on paper or electronic. So the first step is to better understand what are the cognitive resources, the abilities that people need to understand. And then what are the processes involved in understanding that place demands on those resources, and is it different in an electronic versus a paper environment? And then hopefully that will provide a firmer sort of scientific basis for coming up with interventions that are more targeted for helping fix the problems that are there. And at each stage, we're heavily dependent on various kinds of theories. There's a large body of research on what aging does to cognition, and how health literacy works into that. So for the first step, we rely, for understanding the processes of comprehension, we rely on theories of text processing, language comprehension, multimedia comprehension processes, and then these same theories may help us come up with innovative solutions, design-based solutions. So let me tell you a little bit, let me burrow into the first step of understanding cognitive resources in more detail. What I'll do is talk about a general approach that we call a process knowledge model of health literacy. The basic idea, I know that's a busy slide, but the basic idea is, like many other people here, Mike Wolf and Ruth Parker and others, we kind of look at health literacy as a function between the resources that patients bring to healthcare and the demands on those resources that self-care tasks like taking medication require. I won't go through all the boxes here, but following cognitive aging theory, whoops, that's interesting. Okay. Sorry, I'm confusing myself. We're going to focus on processing capacity, working memory, processing speed in relation to aging, which constrains comprehension. And then we also focus on knowledge, which is a potential way of scaffolding better comprehension related to language or domain-specific like health knowledge. Okay, so to make this a little more tangible, and this is sort of the more micro-level analysis that we do, let me illustrate by taking us through some of the cognitive work we have to do when we understand a seemingly simple sentence like take one tablet every day that you'd find on a label. So there's various word level processes. You have to recognize the words and you're sort of activating nodes in a mental dictionary that represents your understanding of the associated concepts. So things like warfarin might be a little more challenging for that process than other words. That's certainly not enough for comprehension. You also have to put those concepts together to understand, well, what are the ideas that that sentence is conveying? Something about an action of taking a tablet. How many tablets? What's the frequency of doing that? So you put those concepts together to kind of get a sense of, well, what's the basic content of this sentence? And that will take you some way towards comprehension, but certainly not all the way. What you really need to do is elaborate those ideas, the mental representation of ideas, with knowledge about medication, other domains, to come up with what is generally called a mental model or a situation model of the task, where you're fleshing out the ideas with inferences to figure out, well, how am I actually going to take this? So it's sort of a mental simulation idea. So in terms of the model, we know that aging is associated with reduced work processing capacity. That's a constraint that makes those component processes harder to do, less efficient, less accurate. Knowledge, on the other hand, can make them more efficient. And we also know that with age, we grow that knowledge through literacy, through encounters in healthcare contexts, although part of the problem of low health literacy is maybe not doing that as well as people with higher health literacy. And so what we're trying to do is to think about decomposing health literacy into age-related concepts that may interact in terms of how they influence comprehension, decision-making, self-care behavior, and the action is in the interplay of processing capacity constraints and knowledge-based facilitation. I won't go through all of this, but this is just one example of research that's kind of what's consistent with that model, where we found that older adults' ability to recall hypertension information in one of our studies was predicted by the Stofla measure of health literacy. Nothing surprising there. That's been found many times. And then we were able, through a mediation analysis, to account for a lot of the relationship between the health literacy measure and recall in terms of processing capacity and knowledge. And the interactions that were also important for predicting outcome. So back to our three-stage model here. Let me go to a little bit about, so we've analyzed these resources, processing capacity and knowledge. Well, how does that influence comprehension, the different processes of comprehension? I don't have time to go through all the work we've done here, but just to kind of do a thumbnail sketch of some of the work that many people have done, including us. At the level of recognizing words, we know that things like longer, less familiar words are recognized less well. There's design challenges related to jargon. Concept integration is also influenced by health literacy resources, lower health literacy resources, that leads to poor memory for information, and also at the level of elaborating concepts with knowledge, low health literacy resources impair that process. And so poorly organized text and complex or irrelevant graphics especially may undermine comprehension. And that's especially likely in digital environments. So finally, because I'm running out of time, let me go to one of our intervention studies where we're trying to target particular comprehension processes and reduce demands on processing resources and help people leverage knowledge they have to improve comprehension. It's a multifaceted approach to redesigning web-based information. what we did was we went and found actually good examples of healthcare information about hypertension from the Mayo Clinic, NIH, various places. This is an example of one of the texts that we found. And then what we wanted to do was develop a multi-level comprehensive approach to improving comprehension and memory of that information, guided by our findings, theories, and a lot of the work that's been done and it's been talked about in here from people in health literacy. We had an interdisciplinary team of people, medical specialists, behavioral scientists such as myself, computer scientists, because this is relating to web-based environments, and patients. And then we sort of systematically went through, in terms of content, we talked about, well, what's the information that has to be done or has to be conveyed? And that was where the medical specialists came in. It's really important. Maybe we can use familiar concepts to help leverage pre-existing knowledge. Language, this is the part that we know the most about. Simplify language, shorter words, shorter comprehension, and maybe familiar words and sentence structures that might especially help older adults who have a lot of literacy experience. And then most of interest for us was, well, how do we organize that information? So we found that the information was kind of disjointed in different places, so we did a lot of work around logically ordering the information. Medication information, there's work I've done many, many years ago about patients' expectations about a flow of they want to see information in a particular flow of information. So we also were careful about the signals we use, the titles, headers, advanced organizers. And then we used, to some extent, multimedia layout to re-emphasize that patient-centered organization of the information. So just to show you, we went from the sheet on the left to the sheet on the right, where we were really focusing on a concept map or a pre-organizer to help people get a sense of the flow of topics, how they're going to expand, and maybe activate knowledge. We had 100 people read both the typical and the revised passages on the computer at their own pace, because we were interested in how well they could kind of evaluate and efficiently read. And they summarized the main points and then answered questions. I'm out of time, so let me just give you the bottom line. The revised passages were better understood, better remembered, whether the questions were about inferences or more explicit information. People, older adults were more efficient. They needed less time to remember the information, especially higher health knowledge people, so that advanced organizer may have really helped people who already had some knowledge and kind of primed the concepts. And so to sum up, older adults' memory for online self-care information was improved by a sort of multi-level comprehensive redesign. And I think the most important part was reorganizing the content and really systematically signaling it for people. And the efficiency measure probably speaks to the importance of providing guidance for self-regulated learning to figure out how can I efficiently read in order to save the resources for integrating this with the next thing that I'm going to read. Okay, I will stop there.